Hey gang, it's me again. We're going to continue our lessons in ECG today, and we are on lesson 5, and we're going to talk about atrial rhythms today. Before we do that though, I do want to take a minute and just do a quick review of some things, just because I think it's always good to look at fundamentals of the ECG as we add new concepts. So let's talk about a couple of brief fundamentals that we've already had a chance to play with, but I want to just make sure that we're all on the same page. So speaking of the page, as we look at the ECG paper here, remember that in this direction we're traveling at 25 millimeters per second, which means 5 big box is equal to 1 second, and that means 25 little boxes is equal to 1 second, hence the 25 little box and the 25 millimeters per second, right? Because we know a little box is 1 millimeter in all directions, right? 1 millimeter up and down, 1 millimeter side to side. So we could use this information to figure out how far 6 seconds is, for example. So we know that if 5 big boxes is 1 second, then multiply that by 6, so 30 big boxes is equal to 6 seconds. And then if we count the number of QRS complexes in 6 seconds and we multiply that by 10, it gives us our average rate. Speaking of rate, let me show you this down here just as a reminder. Lots of different ways to calculate rate. We can actually do a little bit of division in our head, and if we're counting big boxes, we can say 300 divided by the number of big boxes that separates our complex gives us the rate. So for example, if you're looking right here at this example, there are 4 big boxes that separate our complex, so 300 divided by 4 equals 75. Okay, or similarly right here there are 5 big boxes that separate our complex, and 300 divided by 5 is equal to 60. And we'd already talked about in some other venue the fact that you can also, based on that information, sort of know that this is 300, this is 150, this is 100, this is 75, this is 60, 50, and so forth. And that's all just proved by math. Now, one of the things that sometimes comes up when people are trying to calculate rate is they say, well, I've got a couple of R complexes, but I don't exactly know how to calculate the rate. So one of the things I like to do is, let's say I've got an R complex here that separates these two, and this one is in between a couple of little a couple of little boxes, and then this one lands on a box. So I would count the number of boxes, which would be 1 box, 2 box, 3 box, 3.5. And so if it really came down to brass tacks, you could do 1500 divided by 3.5 and see what that comes out to be. By the way, 1500 divided by 3.5 is a whole lot. So the 400s, and we're not typically going to see rates that fast, but that wasn't really the point of the example. The point of the example was just calculating rate when you really are trying to get something a little more specific. Okay, so while we're having this conversation, let's also just briefly recall the elements of the cardiac cycle. So we have our P wave representing atrial depolarization. PR interval is the start of the P to the start of the QRS. QRS complex starts right here and goes up and down in this way, and then we get back to the isoelectric line here, which is the ST segment. And remember, we have another isoelectric line back here and another one over here after our T wave. And then our T wave, which represents ventricular repolarization, is split up into two repolarization zones, right? We have over on this side, we have the absolute refractory period, and over here we have the relative refractory period, which means that if we go ahead and drop a conductive amount of energy right here, even though we're not completely repolarized, we could go ahead and depolarize. Okay, so just a quick review from some fundamentals, and then now what I want to do is move on to a review from last week. So last week we talked about the vanilla rhythms, the sinus rhythms, and we talked about the criterion for this, and I think at this point we'll refer to this criteria as sort of our primary survey of ECG. And you know, primary survey is a very important piece of medicine, because the primary survey basically says, you know, every time, for example, I approach a patient, I look at them in the same way to try to identify their level of illness. So when we look at an ECG, knowing that we can get very specific and important information here, I'd recommend you do a primary survey of the ECG. And one of the reasons it's important to approach this the same way every time is so that you don't miss things, because it's very easy to be distracted by something abnormal and then completely miss something else that may even be more dangerous. So when we're looking at our general rhythms, the primary survey I think goes something like this. So first thing I want to know is the rate. And the reason I want to know the rate first is because the rate is the thing that most of the time is going to kill people. I think I've told you that before in another lesson, but it bears repeating here. So the rate is dangerous, and we want to make sure that it's not too fast and not too slow. And then, of course, we're going to look at regularity, because regularity is going to give us clues into the underlying rhythm and help us understand what's actually going on. And then I want to know, is there a P before every QRS complex? Is there a QRS after every P? And then I want to know about my PR interval. And the two things that we'll be looking for as we move forward, we're going to look at the size of the PR interval, and we're going to look at the regularity of it. Okay, and we'll talk more about that probably next week. But the size and the regularity, and then I want to know the QRS duration. And in general, I want to know, is this narrow or is this wide? And for something to be narrow, it's going to be less than 120 milliseconds, which is 3 boxes. If it's going to be wide, it's going to be greater than 120 milliseconds. And at some point, not today, we'll talk about the significance of that. But just to review, our primary survey is really, you know, this rate and regularity and P before every QRS, QRS after every P, and then we're going to throw in there our PR size and regularity and the size of our QRS complex. So the first thing I want to do as we review from last week then is let's look at this rhythm. And as you recall from last week, this rhythm bears the name of normal sinus rhythm. So I want to once again break this down so we can understand what it means, and let's apply our rules to it. So normal means the rate. The rate is normal. So that means the rate falls within the intrinsic rate of the sinus node, which, as you recall from previous conversations, is 60 to 100. And then we call this sinus because we believe that this is most likely coming from the sinus node, although in reality the best we can say is that it's coming from somewhere in the atrium. And then the R simply stands for rhythm. But what are the criteria for normal sinus rhythm? So as we look at our primary survey of the ECG, what do we say first? We say rate, and this rate is somewhere around 75 or so, right? 1, 2, 3, 4, 5, 6, 7, 8, and that's around a 6-second strip. So this rate's, we'll call it 80. And then the rhythm, right, to figure out rhythm, by which I mean regularity, is by looking at these R to R complexes, right? So is the distance between the R to R complexes the same, or is there variation? And if there's variation, is it less than about 10%? So in this case, they're all the same, so this is going to be regular. Okay, and then we ask our P-wave questions. Is there a P before every QRS? And the answer is yes, there's a P before every QRS. And so we'll say yes. And then is there a QRS after every P wave? So in other words, do you have any P waves that are just hanging out unconducted? And the answer is no, there are no unconducted P waves. So that means there is a QRS after every P wave. So if we want to take this a step further, we can look at our PR interval. And in order to meet criteria for normal sinus rhythm, our PR interval needs to be less than 200 milliseconds. Okay, so what I told you before, as you recall, the distance of the big box is 200 milliseconds. So the best way to do this is to eyeball the size. So we know, for example, if I'm going to look right here at this QRS complex, that this thing sits right here in a big box. And so as long as the PR interval occurs within the entirety of this big box, we should be good. So QRS complex peaks here, and then my PR interval starts there, and so I'm well within that big box. So I know that means it's less than 200 milliseconds. And then the other thing that I want to look at, which is going to become very important later, is I want to look at all of my PR intervals, and I want to make sure that the P waves all look the same and that the interval is all the same. And in this case, we meet that criteria. So the P waves are cool. Alright, so now we can take this next one, and we can probably do this a little more quickly since we are, after all, reviewing, and hopefully you've had some time to find some examples on the Internet of Things so that you can look at this. Okay, so as we move on to this next one, we'll just assume this is a 6-second strip, and let's do our quick primary survey. So the rate, it's too slow. Okay, we're going to call it 40. And as we look at this, we note that it's pretty regular, that the distance between these R to R complexes is about the same. So we're going to call it regular. And what are we looking at next? Our P waves. And so we have a P wave here, a P wave here, a P wave here, presumably one over here. So we have a P before every QRS. So P before Q, yes we do. And then we have a Q after every P. Q after P, yes we do. And then I'm going to erase some of these scribbles to make it easier to see. And so here we have a narrow QRS complex. Alright, so narrow QRS. And then we have a PR interval that appears to be less than 200 milliseconds. So I don't have a QRS complex that lines up on a big box very well, but maybe I'll have one for a PR interval. Don't really see one that lines up on any big boxes, but this one is probably the closest, so let's just zoom in on that bad boy and see what we have. And so we're starting in the middle of this and going to here, so there's 1, 2, 3, so that PR interval is 0.16, because remember 4 times 4, so that's well within our 200 millisecond rule. So this is a PRI of 160 milliseconds, and as we look at our PR intervals, as we go across our strip here, they all appear to be the same. Okay, so this appears to be a sinus rhythm, but because it's below the intrinsic rate of the sinus node, we're going to call this sinus bradycardia. Okay, and remember, when we're talking about things in medicine and we're talking about the rate of something, brady means slow and tachy means fast most of the time. Alright, let's look at a couple more of these and then we'll move on to some new information. So again, we're reviewing because reviewing is very important. And so let's look at our primary survey here. So primary survey. So as we first look at this and we look at the rate, we say, yep, that's fast. In the too slow, too fast, just about right question, this definitely hits the too fast. And as we look at this, we're going to say the rate is somewhere around 150. That's fast. We're going to look at the regularity of this rhythm, and we're going to notice that it's pretty regular. The distance between here to here is about the same as there to there, and there to there, and there to there. So we're going to say that's regular. And then we're going to ask our questions about some P waves, right? So is there a P before Q? And the answer is yes. There's a P before every QRS complex, and then there's a QRS after every P. Well, let's make sure. So every P wave along here, yep, in fact, is followed by a QRS complex. And then we'll take this a step further and we'll say, is our QRS wide or narrow? It's definitely narrow, which means it's less than 120 milliseconds. Let's zoom in here and see. Okay, so this one, for example, starts here and starts here. And so really, I mean, that's about a 40 millisecond QRS complex. That's pretty small. And trying to figure out what happened to my screen. So here we go. So QRS is narrow, around 40 milliseconds, and then our PR interval is also very small, and it helps us here because we see this one that starts on a big thick line, and so I can back up to this right here, and that's going to be the start of the P to the start of the QRS complex, and so basically it's about 2 whole boxes. So that PR interval being 2 whole boxes is going to be a whopping 80 milliseconds, and they all look the same. So that meets all of our criteria to be sinus in nature, and since this is fast and it's sinus, we're going to call this sinus tach or sinus tachycardia. So our last rhythm from our previous lesson is sinus arrhythmia, and for the sake of time I'm not going to go all the way through the primary survey, but we know this is a 6-second strip, and so there's 1, 2, 3, 4, 5, 6, 7, 8 QRS complexes. This is irregular, of course, but otherwise it meets all of the criteria to be sinus. It has P waves that all look the same. It has small PR intervals, small QRS complexes. So if this is otherwise would be a sinus rhythm, except for the irregularity of the rhythm, then we call this sinus arrhythmia. So as we move on here, we'll see some other examples of some sinus type rhythms. So we see this rhythm here where we actually have a couple of things happening. So we notice from here to here and here to here and here to here is a pretty nice sinus rhythm, right? It meets our criteria. It has a narrow QRS, narrow PR interval. It looks nice and regular from each R to R, and then all of a sudden we have this thing here, and it comes early compared to where we think it should be. And now as I take a 30,000 foot view of this rhythm strip, same thing looks like it's happened right here. And one of the things you'll notice about this premature atrial contraction is that the P wave here looks the same as the P wave here on its other early beat, but it looks different from these other P waves all the way through here. And the reason for that is if we think back to anatomy and physiology, remember I told you one of the things that cells of the heart can do is they can be conductive, or they can be pacemaker cells, right? They can have some automaticity. So if I think that the rhythms originating here in the sinus node, and then electricity is making its way through here like we've talked before. But then for whatever reason, a little irritable foci somewhere in the atria decides it's going to occasionally throw off some electricity. Well, because this place is different than this place, it's going to have a different morphology to the P wave. And so that's one of your clues, is that if you have a different morphology to your P wave like you do here and here, then that tells you that this beat originates somewhere in the atria, because P waves typically represent the atria, but it's a different place than these because the P wave has different morphology. So this next rhythm we're going to talk about is actually very common in the wild, and you will see it quite a bit. And atrial fibrillation can actually, for some reason, be pretty confusing, and I understand why that's the case, and we'll talk more about that later. Right now we're simply looking at some fundamentals. And so one of the things I want you to notice before we talk about how we're going to review atrial fibrillation is I want you to look at how scattered all this stuff is. And it looks like you took your pen and you just drew some wiggly lines in between the QRS complexes. And so you might be asking yourself, what do these squiggly lines represent? So let's go back again to our very sophisticated picture of the heart. And remember, I told you that in a normal cycle we have an origination right here of our electrical focus through the sinus node. But what happens in atrial fibrillation is you get multiple ectopic foci, and they're all firing at once, and they're showering electricity from top to bottom. And as you recall from our previous conversations, right here at the AV node, electricity tends to be slowed, and we've got to be able to have enough time to actually repolarize, at least get into the relative refractory period. And so what happens is we basically shower a bunch of disorganized atrial foci down towards the ventricles, and then a few of those will make their way through the AV node and on into the ventricle. And so the net result then is that you end up with a very irregular rhythm that is difficult to predict. And so we refer to this type of irregularity as irregularly irregular. Okay, and so this is the buzzword for atrial fibrillation. If something is irregularly irregular, then you should really be talking about atrial fibrillation. So in this example here, as we look at our primary survey, there's a couple things that we notice. So first thing I want to talk about is the rate. So we'll assume this is a 6-second strip. 2, 3, 4, 5, 6, 7, 8, 9, 10. So that's 10 in 6 seconds, so that means our rate's 100. So we're right on that tachycardic kind of borderline right there. And then I want to look at, so there's our rate. Our regularity, we already said, is irregularly irregular. And then I want to look at our QRS and P's. So we see all these squiggly P's through here. And so the question is there a P wave before every QRS? Yeah, you can argue that there is, but the reality is they're not organized. So I would actually say no. And one of the things to keep in mind about atrial fibrillation is when we talk about the P waves, since they simply look like scribbles, looks like one of your children made this, so we're going to say that these P waves are indiscernible. So the P's are indiscernible. Indiscernible. Nobody ever accused me of being a good speller. So the P waves are indiscernible, and so then it's really difficult for me to say that there's a P before every QRS or a QRS after every P. One of the things you will notice in this atrial fibrillation model is that we still have a narrow QRS complex, and then as we like to look at our P waves and our PR intervals, we really don't have a PR interval because we don't have discernible P waves. So when you're looking at a rhythm and you find that the P waves are indiscernible, the rhythm is irregular, you can't find a PRI, then that's a pretty good hint that you're looking at atrial fibrillation. And one of the things we talk about is we talk about different flavors of atrial fibrillation, and we talk about AFib with controlled ventricular response, which basically means it's AFib with the rate less than about 100, or we talk about AFib with RVR, which means rapid ventricular response, and so that refers to atrial fibrillation with a tachycardic rhythm. So I really want you to practice atrial fibrillation, find examples online, whatever you have access to that can help you show you even more and more examples, because like I said, atrial fibrillation is very, very, very common. You will see this lots and lots in the wild, and this will be important as you study ACLS and the emergency management of dysrhythmias, because this is one that you'll deal with over and over and over again. So the next rhythm we'll talk about is kind of a cousin of atrial fibrillation and sometimes difficult to differentiate, but we'll see if we can't do it. So this one is called multifocal atrial tachycardia. So as the name suggests, we have multiple foci within the atria that are sending signals to the ventricles for depolarization. So how do we differentiate this from atrial fibrillation? Well, I think one reality is that oftentimes MAT is so close in appearance to atrial fibrillation that they do oftentimes get accused of being the same. But let's see if we can figure out what these look like. So let's go back to our primary survey, right? So first thing I want to know here is the rate. And is the rate too fast, too slow, or just about right? We'll just eyeballing this thing. It looks pretty fast, but let's go ahead and do a 6-second count and see what we come up with. So here's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So the rate is 160. Well, that's a fast dude, as we know. 160 is way too fast. So we've already fallen out of criteria to be normal anything, but nonetheless, that's a fast rate. And then we're going to ask ourselves, is this regular or is this irregular? And it's definitely irregular because it seems to just kind of be going all over the place. Is it regularly irregular or irregularly irregular? It's a little bit difficult to say, but I think compared to this example up here, it may be a little more regular, but either way, we're going to call this irregular. And then we're going to ask ourselves some P wave questions. And so the first thing is, do we see P waves? And the answer is yes, we do actually see P waves in this example. So let me see if I can find some P waves to show you. So here's a P wave, and then here's a P wave, and then definitely here's a P wave, and that's probably a P wave, and that's probably a P wave, and that's for sure a P wave, that's probably a P wave. There might be a little P wave in here, probably one there, definitely one there, definitely one there. And so what you'll notice is there are some discernible P waves for certain, but they have a tendency to look a little different than each other. And so let's see how many of these things we can find that might look the same. So we'll try a color scheme here. And so I'm going to use the easy one first. I know this one right here looks kind of like this one right here. They look a little similar. And that may be too generous, honestly. But for now, we'll just say they look similar. So then, let me find another color here. And let's see what else we find. So I've got this little dude here that looks kind of like that little dude there. And then let's pick another color. We'll do some fuchsia. And I've got a couple of these where I've got this, and I've got this, and maybe another one kind of similar to that, and similar to that. And so in this situation, I have at least 3 different P-wave morphologies. Okay, so similar to atrial fibrillation, I'm getting a bunch of electrical activity from different parts in the atria, but probably not so haphazardly as I'm getting in atrial fibrillation. Okay, but the net effect is this is going to look very much like atrial fibrillation, and it's going to be very difficult to tell the difference. And I think the reality for us is it probably doesn't matter much, because our approach to these narrow, complex, irregular rhythms is going to be about the same. So as we kind of work our way down our criterion then, is there a P before every QRS? And I think the answer is probably. You could argue a couple of these where maybe the P wave is pretty difficult to understand, but I think by and large there is a P wave before every QRS, and then subsequently there seems to be a QRS after most of the P waves. Is it possible to say for sure there's a QRS after all of them? I think the answer to that is no. And then it's really difficult here to come up with any sort of PRI measurement, but what I can pretty clearly say is that our PRIs are not the same. And then finally I can look at our QRS complex and I can say they're narrow, which is usually a pretty good indication that whatever I'm looking at is coming from the atria. I have just 2 more that I want to show you, and then we'll be done for this lesson. So hang on, we're almost there for our atrial discussion. So this next one is called a wandering atrial pacemaker. And it's called wandering because similar to what we just reviewed with atrial fibrillation and with its friend, the multifocal atrial tachycardia, the P waves have different morphology, which indicates that there are different foci in the atria producing the beats. So as I look at this, I notice right away that the rate is okay. So let's just say what it is. It's 1, 2, 3, 4, 5, 6 times 10 is 60, so the rate is 60. And then I do notice this is irregular, and that's not to be unexpected when we are originating our ventricular contractions from different foci. And then as I look at this, there is a P wave before every QRS complex, and similarly there's a QRS complex after every P wave. One of the things you notice with this particular strip, though, is that the P waves have different morphologies. So there's that P wave, and then there's these that look pretty similar, these 3 here, and then this one looks different, this one looks different, and then we get back to this one that looks kind of like the ones we saw originally. So when you see something that's irregular, has a fairly normal rate, but then the clue here is that the P waves have different morphologies, you need to be thinking about the wandering atrial pacemaker. Alright, so we're in the home stretch to be done with this one. I want to show you this briefly, and I'm going to find a better example for our review in the next lesson. But I want to briefly talk about the concept of SVT. And SVT, in the purest form, means supraventricular tachycardia. And so we've learned before that tachy means fast, and supraventricular means anything originating above the ventricles. And so theoretically, any tachycardia of any origin that originates above the ventricles could be SVT. And SVT oftentimes represents a re-entry phenomenon where, for example, if we go back to our drawing here, as electricity is coming from the atria down the AV node and into the ventricle, sometimes you can get a short circuit that brings it up here, and then it creates an electrical loop which speeds up our rate substantially. And so, as you'll learn when you take pharmacology, we oftentimes use AV nodal blockers to reset this. So we often use something that'll stop it right here in its tracks to reset that short circuit. But one of the things about SVT is its rate is usually fairly consistent around 150, which we have a rate here of 150. It typically isn't going to vary much with the respiratory artifact. And the other thing that can be frustrating with SVT is you may or may not see a P wave. In fact, you'll probably more often than not find a P wave. In this example, we do see a little P wave here, but we meet the rate criteria to be SVT, although some would argue that this is sinus tach because we see a P wave. But I'll argue that in an adult, if the rate's 150 or above, we're outside of sinus tach range most of the time, unless of course we're actively exercising and trying to get the heart rate up towards its maximum. And remember, just for trivia points, if you're ever on Jeopardy, maximum achievable heart rate is 220 minus the patient's age in years. So the younger you are, then the faster your maximum heart rate should be. So the last thing I want to talk to you about is a rhythm called atrial flutter. And atrial flutter is an atrial dysrhythmia that is a cousin of atrial fibrillation or multifocal atrial tachycardia. But the difference between atrial flutter and atrial fibrillation is that atrial flutter, number one, tends to be more regular. So you notice here the R-to-R intervals are pretty regular, pretty able to be predicted and march out. But the other thing that you'll notice with atrial flutter, unlike atrial fib where we really don't have discernible P waves, with atrial flutter you get this what's called a sawtooth appearance to the P wave, where it literally looks like you could take a piece of wood and run this rhythm over it and you're going to cut a hole in it, or cut it in two. And so this sawtooth appearance right here, this represents atrial depolarization, but of course only a few of them are being conducted through the AV node so that they can be conducted through the ventricles. One of the things we tend to do with these flutters is we look at the number of P waves per QRS complex. So in this case, it looks pretty consistent that there are 3 P waves for every 1 QRS. So here's a P, here's a P, here's a P, here's a QRS, and then 1, 2, 3 QRS, 1, 2, 3 QRS. So I would call this a 3-to-1 block, and sometimes you can have other blocks 4-to-1, 2-to-1, whatever the case may be, or they can be variable, meaning that you may have some of these come along that are 3-to-1, and then maybe you've got one that's 2-to-1, or maybe one that's 4-to-1. But it's easy to look at the flutter and figure out what's going on. But again, in this case, I would call this a 3-to-1 block. So atrial flutter, it can be fast, it can be slow, just like its cousins atrial fibrillation. Again, it's treated essentially the same, has very similar risk profiles in terms of long-term outcomes and so forth. You will see atrial flutter in the wild, just like you will with atrial fibrillation, but you'll see atrial fibrillation, in my opinion, a lot more commonly than you will atrial flutter. So again, remember atrial flutter, get this thing to right here. Atrial flutter is going to be sometimes regular, sometimes not regular. It is going to have the sawtooth pattern, and oftentimes that's predictable, but it doesn't have to be. It can be a variable block. And then most of the time with atrial flutter, you will see a narrow QRS complex, since it does originate with an atrial focus. Okay, so narrow QRS, sawtooth appearance, may be regular, may not be, may be fast, may be slow, may be normal. But the thing that's going to give it away is that this looks like the teeth on a little handheld saw. Okay, so don't put your fingers in there. You don't want them to get cut off as you're analyzing the atrial flutter. Alright, well that is it for this lesson on atrial dysrhythmias. Again, in the next lesson we'll talk some more about these. We'll do some reviewing. I'll see if I can bring a better example of SVT next time as well. And we will next week move on to bigger and better things. As always, if you have any questions, reach out to me, and I'll do my best to try to help answer your question. Thanks for listening.